Warm good afternoon to one and all. I would like to introduce our speaker. She is Dr. Rekha Raichel Kuriakose, MS DGOD, MRCOG UK. She is our very dear colleague, a very integral part of our obstetrics department, a very calm, composed and humble person, and yet a very brilliant academician. She's graduated from Government Medical College, Trivandrum, and did her Masters of OBG in Government Medical College, Kottayam. After that, she is a member of the Royal College of Obstetrician and Gynecologists, UK. She is accredited by the Fetal Medicine Foundation, UK. She also got her Masters in Fetal Medicine from University Hospital, Bristol, UK. She has been practicing fetal medicine for the last 9 years. She joined our hospital in 2016. Before that, she was working in the famous Simon Hospital, Cochin. She is also trained to do targeted fetal scan, fetal echo, and invasive uterine procedures. She is an asset for us, and we're very fortunate to have her with us. A person whom we always look up to for expert advice. And she's got a very interesting topic for us today. Fetal anomaly, is it rare? A BCMCH experience. Welcome you, ma'am.
Thank you, Dr. Sunita. Good afternoon, everybody. So my topic is fetal anomaly, and most of us are parents sitting here, and parents or grandparents. So every mother wishes to have a normal, healthy baby. And always, we are not so fortunate. Sometimes we may see babies having problems or anomalies, which may cause disability to the baby, or at times it may be even life-threatening. So the specialty of fetal medicine came into being, and this famous person is Professor Kypros Nicolaides, who is considered as the father of fetal medicine. He started screening for Down syndrome, all congenital anomaly screening programs, and we all follow him today. And he is the person who is in charge of the Fetal Medicine Foundation, and all our scans, our first trimester screening are all accredited by the Fetal Medicine Foundation UK. So, what is congenital anomaly? Fetal anomalies can be chromosomal or structural, and today I'll be dealing more with structural anomalies occurring in the fetus, and these anomalies can be identified in the intrauterine life. Sometimes they are identified only at the time of birth, or sometimes we can miss even at birth, and it will take some time in infancy for these anomalies to appear. The overall prevalence of anomalies is 2 to 4%, and according to WHO, more than 3 lakh newborns die within the first 4 weeks of birth worldwide due to congenital anomalies. Apart from this, these anomalies can cause long-term disabilities in the babies, which can have a significant impact on the individuals, the families, healthcare system, and the society. There are a lot of causes for anomalies. It can be genetic factors, environmental factors, infections occurring to the mother, or socioeconomic condition, especially folic acid deficiency can cause certain anomalies. The common anomalies that we come across are cardiac defects, neural tube defects, and Down syndrome. We screen for anomalies by a targeted imaging done between the 18th and 20th week of pregnancy. Down syndrome is an entirely different entity which can be detected as early as the first trimester of pregnancy by the nuchal translucency scan. As you can see in the picture, we take this measurement. This is a normal fluid collection behind the neck of the baby. This value, when it is coming less than 3 mm, is considered as normal. Any value more than 3 in a baby is showing that the baby has a high risk for having chromosomal anomalies, mainly Down syndrome. And then we have to offer invasive testing in these babies. So coming to congenital anomalies, I would like you to have a look at a normal baby in the second trimester. It's a normal fetus, a clip of a normal baby. So now I would like to share a few of our abnormal cases with you. This is a postnatal picture of an anencephalic fetus. Anencephaly is a condition where the fetal skull and brain matter is absent. This is a lethal congenital anomaly, that is, this baby won't survive once it is born. We also had one such fetus. As you can see, the gestational age was 13 weeks. This is one anomaly which we can detect as early as the first trimester of pregnancy. If you look carefully, the skull bone is absent here, and you can see the brain matter protruding out. But when I did scan for this fetus, I was in for a surprise because this was actually a twin pregnancy, that too a monochorionic twin pregnancy, that is, babies sharing the same placenta. And the other baby was completely normal. If you can look here, the baby down is normal, and the upper baby was having the problem. So we talked to the mother. The mother decided to continue the pregnancy for the sake of the healthy baby. We did invasive testing to make sure that the healthy baby was chromosomally normal. She continued pregnancy, and I would like you to have a look at an encephalic fetus in the third trimester. You can see the typical frog eye appearance with complete absence of cranial tissue and skull mold. She delivered with us about more than a year back, and the other baby is completely fine, and she occasionally comes to visit us. The other common anomaly is an open neural tube defect or spina bifida. As you can see in this picture, there is a defect in the vertebral column whereby the spinal canal is open and the meninges and sometimes the spinal nerves are seen and close to the sac lying outside the body. Now I would like to show you one of our fetuses. Here you can see a defect in the lower part of the spine, and the same. This is the antenatal scan image, and this is how the baby will look once it is born. Here, the problems are in these conditions, depending on the level of lesion, the baby may or may not be able to walk once it is born. Sometimes paralysis or paraplegia can occur. Bladder bowel dysfunction is also a problem. So in this case, the parents can take an informed decision whether or not to continue the pregnancy. This is a 4D image of a normal fetal face. You can see the baby opening and closing the mouth. It's a normal baby. Now, the most common facial anomaly that we encounter is a cleft lip. It is seen in 1 in 700 live births and more common in diabetic mothers. We have had our share of cleft lips, and this is one of our ongoing pregnancies. And you can see a unilateral cleft in the upper lip extending into the roof of the mouth. And in this case, there was a cleft in the hard palate also. The good part about this anomaly is this is correctable since we have a pediatric surgeon. She's continuing with us, and we are expecting the surgery to be done with us once the baby is born. So in this case, this fetus had low set ears, the chin is receding backwards as well as it is very small. The trognathia is with micrognathia. You can see the fingers are clenched and overlapping. There was single umbilical artery, polyhydramnios, LICA was very high. There was growth restriction and there was gross cardiac anomaly also for this fetus. Putting all this together, we considered a chromosomal problem, Edwards syndrome, and postnatally it was confirmed. This baby was referred to us late in pregnancy, so we couldn't do anything. She continued with us, delivered with us, and postnatal karyotyping showed trisomy 18 or Edwards syndrome. Here, this is a lethal anomaly. If we can detect it during our second trimester anomaly scan, we can give an option of not continuing the pregnancy. The other condition which I would like you all to have a look at is diaphragmatic hernia. Here you can see this is the diaphragm which separates the thoracic components from the abdominal cavity. And when there is a defect in the diaphragm, you can see the bowel as well as the stomach is in the thoracic cavity. And this is an image showing the diaphragm, and you can see the heart is pushed to one side and the stomach is in the thorax. Again, a video clip. Here you can see this is the diaphragm, and here you have the heart on one side and the stomach is in the chest cavity. This is one condition. If you diagnose antenatally, you can completely save the baby, because if we miss it in the antenatal period, once the baby is born, we may not be able to, this baby won't survive. We have to intubate the baby immediately after it is born, and surgery has to be done. In this case, this baby was saved by our neonatology and pediatric surgery team. Again, OUTFLOW is a condition where there is a defect in the anterior abdominal wall through which the abdominal contents, the liver, the intestine are seen lying outside in a sac. And this condition is usually associated with chromosomal problems like Down syndrome or Edwards syndrome. And the outcome is usually very bad. We had a case in the first, detected in the first trimester. This is the umbilical cord, and you can see the abdominal contents lying outside. The patient decided not to continue the pregnancy. Now coming to cardiac anomalies. Before going into anomalies, I would like you all to have a look at a normal heart. This is the four-chamber view of the heart, how it appears in ultrasound. You've got two atria and two ventricles. This is the left side, so left atrium, left ventricle, mitral valve, right atrium, right ventricle, tricuspid valve, interatrial septum, foramen ovale, interventricular septum. And we have two pulmonary veins entering the left atrium. Here you can see the left ventricle and the aorta coming out of it, the same in color. And you have the pulmonary artery coming out of the right ventricle and branching. This is the arch of aorta feeding off the neck vessels. So I'd like to have you to have a look at the normal four-chamber view of heart, a live clip. and a normal aortic and ductal arch. So in this video, if you look very carefully, you can see a gap appearing here. This is the interventricular septum with a large gap between the two ventricles. This is a ventricular septal defect. So this can be surgically corrected if this done. If you're careful, you can see that there is only this is the same patient's image. Here there is only one AV valve moving, and there is a gap in the interatrial as well as interventricular septum. This is an atrioventricular septal defect. This condition was also surgically corrected in our institution. This is a cardiac anomaly where you can see the four-chamber view is normal, but there was a common arterial trunk from which the pulmonary artery and aorta was arising. This is a condition which can be surgically corrected. Again, surgery was done in our center. And this is one of the common cardiac anomalies that we come across. This is a tetralogy of Fallot, whereby there is a VSD and an aortic override. You can see the VSD with aorta overriding it. And this is an ongoing pregnancy. We hope she will deliver with us, and so that surgery can be done here. So I hope at least some part of it was clear. So my take-home message is fetal anomalies are not uncommon. We come across them in our practice. So as practicing doctors, we should offer targeted anomaly scan for all our pregnant ladies between 18 and 20 weeks of pregnancy. Early detection is the key in these cases because if we find an anomaly which is lethal, it gives time for the parents to make an informed decision whether or not to continue the pregnancy. And in those surgically correctable cases, even the doctors can be prepared for the birth of a baby, and so a postnatal management becomes easier. And the parents are also mentally prepared for the birth of a child with special needs. Open for discussion. Rekha will clear whatever doubts you have.
What's your experience with torch?
Madam, torch is a non-recurrent cause of congenital infection. Torch does not cause recurrent congenital problems in the baby. So, if the torch infection which occur in this pregnancy cause some anomaly for the baby, it is over with that pregnancy. It won't appear again next time. You can treat the whatever infection was there, you can treat it, and she can forget about it. Next time, she won't have an anomaly due to this torch infection.
Have you come across any torch infection?
Torch infection, IgM, IgG positive cases have come, but we have not come across anomalies. No. Yes, ma'am. But peri-conceptional folic acid is more important. Usually our mothers take folic acid only once she is pregnant. Actually, she has to take it 3 months before she becomes pregnant. That is, whenever she is trying for pregnancy, she has to take folic acid. That too, if she has had a baby with this problem, she has to take 5 milligrams of folic in her next pregnancy.
Thank you so much for an excellent presentation. I have a few doubts actually. The two cases which you mentioned here. Firstly, seeing the adverse influence.
Yeah, trisomy 18.
Yeah, I would say the fact that we decided to continue.
No. She came to us in the 3rd trimester. She was referred from elsewhere in the 3rd trimester. Actually, in our practice as obstetricians, we cannot terminate a pregnancy after 20 weeks. So she had to continue the pregnancy invariably.
And also the other case which we talked about is surplus gastroparesis.
That is the patient's decision whether or not to continue. I offer them amniocentesis and karyotyping. If the baby is chromosomally normal, they can continue. We have had cases where the pregnancy has continued. They decided not to continue the pregnancy.
Thank you.
Always pray for the normal state, not for the major.
That is what our people don't understand.
Yeah.
Always they keep on asking about the sex of the baby. They don't want to know whether baby is normal or not.
Thank Dr. Rekha for this very crisp and actually to see it was very informative, especially to the people outside OBG and pediatrics department, because myself and Dr. Girija belong to the era where scan was also not there to find a newborn with all these abnormalities. And now that we can diagnose all this very early, we can do an in utero transfer to a center where delivery can be catered over there and a cardiac surgery can be offered. In fact, to start with in Kerala, actually, Suresh sir, no such deliveries were occurring at SAT to get transferred very quickly to Sri Chitra for cardiac surgeries. But now that so many centers are there of Kerala, probably with Athram, and things are going much better of it. And still very advanced, even in Kerala, we have centers which offer in utero surgeries and things like that, tracheal tuck, intrauterine, your transfusions and laser for TTTS and such things. So hopefully in the years to come, Rekha will give us clippings of that probably, and let our center get a little more advanced in utero surgery.